Hello everyone, so today we continue with our discussions of nephrology. So if you see a patient who's 35, came in with dysuria, and then you do labs, there is leukocytosis, and then you do imaging, you see 2 centimeter irregularly shaped stone in the distal ureter, and the patient have flank pain, CVA tenderness. What's the best next step? Best next step, you want to remove the stone. And what is the cutoff here? The cutoff is 10 millimeter. So if it's more than 10 millimeter, you want to consider removal. So there are different types of stone. There is magnesium ammonium phosphate stone. What could be causing that? Could be caused by Klebsiella, Proteus, okay? Due to hydrolysis of urea, could yield causes ammonia, right? So what are the features? Your features, you will have pH of urine will be high. You have recurrent urinary tract infections, fever, dysuria, flank pain, pH more than 8, urine pH more than 8. This is very specific. Coffin lid shaped crystals, you can see that. A large Stockholm calculi as well. How do you treat it? You treat it with antibiotic therapy, complete stone removal, percutaneous nephrolithotomy usually required. Okay, you can do urease inhibitor in select patients to prevent recurrence as well. Okay, this is about renal stone. Okay, now the next case that you would see, you see 28-year-old woman comes in with a frequent urination. Okay, urination, and so what you would do, and there's like some hyponatremia and stuff, so you do water deprivation test. You don't give her water, and then you check urine osmolarity. Okay, and then you see the diagnosis. What's the diagnosis? This is a primary you see urine osmolarity after you deprive from water, it'll be 600. So what would be the diagnosis? This is primary polydipsia. Okay. Okay, so primary polydipsia usually can be caused by antipsychotics, dry mouth, like psychiatric conditions. Usually you see high urine osmolarity after water deprivation and doesn't respond to desmopressin. Okay, wouldn't be different. Okay, it's ADH independent, just water intake, you drink a lot of water. And we have 2 other types, diabetes insipidus, central and peripheral, like nephrogenic. Central can be caused by trauma, idiopathic or pituitary surgery, or ischemic encephalopathy. You have urine osmolarity will be low and increased if you give desmopressin, because it's just desmopressin deficiency. Nephrogenic is worse, like either from lithium, hypercalcemia, or hereditary, like mutation and like aquaporin 2 mutations. This one you have low urine osmolarity and does not change when you give desmopressin or ADH. Okay, so that's the difference. Okay, so another case is high yield. Like you see a young guy, like 18-year-old man, comes in with a proteinuria. That's the only symptoms there is. Just you do urinalysis, you see protein 3+. Okay, all the other symptoms are okay. There are no symptoms. But when you do the 24-hour urine, you see 2100 milligram in 24 hours. So this is not nephrotic. Nephrotic syndrome usually have more than 3500. Okay, so what would you do? The best next step here. Best next step, you do spot urine protein creatinine ratio upon arising and at the end of the day. Okay, this is what you want to do, because this can be orthostatic proteinuria. So there's different types of proteinuria. There's transient, orthostatic, and persistent. Transient, this one you have increased in glomerular permeability, seen after fever or after exercise. Orthostatic, usually when you like stand up, is diagnosed by spot urine protein clearance in the morning and the afternoon. Likely altered GFR and hemodynamics and neurohormonal activation in different times of the day. This is nothing to do, it's fine, benign, you don't have to worry about it. But there is persistent to increased permeability of glomerular capillary wall. This one you need renal ultrasound. It could be autosomal dominant polycystic kidney disease, and they need further investigation, or the glomerulonephritis, nephrotic syndrome. Okay. Now, if you see 22-year-old African American male coming with hematuria, okay, and then they ask you what's best next step. This one you want to do hemoglobin electrophoresis. This because this could be sickle cell trait that can cause, okay, impaired ability to maximally concentrate urine in sickle cell trait. Okay, so you do hemoglobin electrophoresis just to confirm the diagnosis. Okay, rare complication of sickle cell trait can cause renal medullary carcinoma, which is malignant cancer, but this is rare. Okay. Now you see somebody who's a 62-year-old man who's having fatigue, swelling in the legs, and protein urea A1C 7.5, and they ask you what's best next step. So the best next step, you want to diagnose what is causing this nephrotic syndrome or renal disease. So what you want to discuss: renal ultrasound guided renal biopsy, ultrasound guided renal biopsy. Because once you know what you're dealing with, yeah, then you can treat it. Always good idea to treat it, because this could be diabetic kidney disease. And the major finding in diabetic kidney disease is that you see persistent albuminuria more than 3 months duration. You see initial hyperfiltration followed by progressive decline in GFR. Hypertension usually present, and the course usually gradual, more than 5 years after type 1 diabetes, and may present other diagnoses of type 2 diabetes as well, non-slow progression. If there is typical features, you can do biopsy. Okay, if there is early onset, like somebody have diabetes and then they develop it like within 3-5 years. If there is rapid progression of creatinine increase like 5 to 10 times, and albuminuria increase in like 1 to 2 years. Okay. If there is active urinary sediment like RBC or white BC cast, if there is combined SLE with diabetes as well, then it's a good idea to get a biopsy, discuss biopsy options. Okay. So, someone, you see 39-year-old, comes in because of a swelling, pedal swelling in leg lower extremity. Okay. And has chronic kidney disease. So what's the benefit? And then you have a protein, daily protein excretion above 1,000 milligram. And this is the best next step. You do ACE inhibitor. It's helpful the most when there is protein excretion more than 1,000. That's when it's helpful the most. Okay. Now this other case is interesting. If you see 80-year-old man comes in with skin rash in his legs, and then there's lace-like purple discoloration of lower extremities, purple lower extremities. Okay. What's the diagnosis of this patient? This one is atheroembolic disease. Okay, this has happened after bone fracture or many reasons. Could cause atheroembolic disease. Sometimes can happen after angiography, surgery, or aortic arteriography. The clinical features usually subacute onset AKI 1 to 2 weeks after procedure, and then you have active urinary sediment like eosinophiliuria, white BC cast, hematuria, mild proteinuria, and then you have peripheral eosinophiliuria and hypocomplementemia. Okay, You see cyanosis or gangrene in toes with intact pulses, and you see livido reticularis as well. Okay, this one in renal atherombolyc disease. Okay. Now there is this woman who's 72-year-old woman, had acute urinary incontinence after recent hospitalization. After hospitalized for knee surgery. Okay, so a rectal exam shows hard stool and rectal vault. So this one's tricky. They tell you, okay, what's the best next step? How to treat this urine incontinence? The way you treat this urine incontinence, you give polyethylene glycol Miralax, because this is constipation causing urine incontinence, so you need to treat the constipation. Okay. Now that brings us to a discussion: management of reversible causes of transient urinary incontinence. If it's caused by severe constipation or stool impaction, you just increase mobility, give fluid, give laxative, stool softener, manual disimpaction if needed. If there's urinary tract infection, just give antibiotics. This is going to treat it. If there's atrophic vaginitis or urethritis, you just give topical estrogen. And sometimes worsen in urinary incontinence in some patients. Sometimes if there's metabolic conditions like hyperglycemia, hypercalcemia, you just treat the underlying cause. Sometimes medications can cause incontinence, so you treat that. If there's alcohol, recommend counseling. If there's impaired ability to reach the toilet, like use bedside toilet, consider physical therapy and assistive device, increase caregiver support. Some patients are just weak, they can't go to the toilet, so they have incontinence, okay? Alright, now you have a patient came in just like 67, came in like with urinary symptoms and then enlarged symmetric prostate. So of course it's a man, okay? Symmetric enlarged prostate. So this is a BPH question, and they ask you what's the best next step for BPH. BPH BNS is behavior modification. Okay, try like to limit caffeine intake, drink less water before going to bed. This will help decrease nocturia. Okay. That brings us to the management of BPH. BPH usually can cause like dysuria, hematuria, medication can cause urine retention. There are a lot of things, so you gotta discontinue those. And usually on exam you can see bladder distension, mass or asymmetry in digital rectal exam. Look for is there any neurological symptoms, is there any asymmetry. These are warning signs, could be cancer, not just BPH. Okay, and then you gotta do urinalysis, prostate specific antigen, serum creat. So in a summary, somebody you have benign prostatic hyperplasia, you assess the mass, you assess the bladder distension, you assess neurological symptoms, if there is any metastatic cancer that spread to the neurons and caused issues. And you check urinalysis, PSA, you can do post-void residual volume as well. And then the way you manage it, first behavioral modification, after that you can do alpha blocker or 5-alpha reductase inhibitors, and you can do invasive procedures like transurethral transurethral section of the prostate, okay, TURP procedure, if the symptoms are bothersome, you know. So here is a tricky question. So let's say they give you a 41-year-old woman, came in because of rash, red spots on her legs, okay? There's also fatigue, arthralgia in hips and knees. So on exam you see some red lesion, like 1 by 0.5 centimeter, scattered on both lower extremities to mid calf, okay? So red lesion, okay, on lower extremities. So you do regular labs. She came in because of rash, fatigue and all of that. So you do labs, shows creatine 1.4, okay. Protein is 2.2 plus, and then you see RBC cast, protein 2 plus. And then they tell you, okay, what is the diagnosis here, and what else do you find, okay? What are you most likely to feel in the body? So that's being a physician, you gotta know from the differentials. So whenever there is red spots on the legs, kidney failure, arthralgia, some abdominal pain, this is Hino-Schollen purpura. Hino-Schollen purpura. So on the kidney, you will see capillary IgA deposit on a skin biopsy. Okay, this is what you can see. IgA deposit on skin biopsy. You also could see that on the kidney as well. So what is the Hino-Schollen purpura? It's an IgA immune complex deposition in small vessels. So it causes tetrad of skin, palpable purpura, joint arthralgia, GI symptoms like abdominal pain or bleeding, and glomerulonephritis and proteinuria, kidney issues. Okay. What are the diagnostic studies for that? You see hematuria, RBC cast, proteinuria, renal insufficiency, and serum complement usually normal, and then you see IgA deposit on the skin is diagnostic, and normal platelet, normal coagulation studies. So always the answer could be biopsy of the skin here. Management after you diagnose it, hydration and onset. You can give a glucocorticoid for kidney failure and severe abdominal pain as well to suppress the immune response. Alright, now we got more cases. Like let's say you get a 31-year-old man had renal stone, and they say how to prevent it. Okay, most common is calcium oxalate. So how to prevent? You want to increase dietary calcium. So you will think that calcium stone, you need less calcium, but no, you need more calcium so that it binds the oxalate, because the oxalate is a problematic issue, calcium oxalate. What other interventions? So if you want to reduce sodium and animal protein, and you want to increase calcium, fluid, straight, and fruit and vegetables. This is what you want to do. Okay? Why? Because if you reduce sodium, this is going to reduce calcium excretion in the urine. If you reduce animal protein, this is going to reduce urinary uric acid and calcium excretion. If you increase calcium, then oxalate absorption will decrease, because in the stomach, calcium is going to bind the oxalate and get rid of it. Okay, so it wouldn't go to the kidney. Increase the fluid, this is going to increase urinary flow, decrease concentration in the urine. Increase citrate is going to decrease urinary calcium. Okay, because it binds urinary calcium to inhibit stone formation. Citrate goes to the urine, bind the calcium, so this way inhibit oxalate from binding the calcium, so that's why less risk of calcium oxalate stone. Fruit and vegetables increase citrate excretion in the kidney, basically. Okay. Alright, so what slow progression of CKD? Dapagliflozin. This is the new kid on the block. It's very helpful for HFpEF and for kidney disease, because SGL, this is SGLT2 inhibitor. SGLT2 inhibitor is going to decrease sodium reabsorption in the proximal tubule, and this will increase sodium delivery to the macula densa, so more sodium. When there's more sodium, this is going to decrease renin secretion and decrease in the vasodilation of the renal afferent arteriole, decrease GFR filtration and proteinuria, and this way you preserve GFR long term, okay? Because it's going to decrease the dilation, so you're not going to dilate too much, you can dilate like just the right amount. When you have less GFR, less proteinuria, this is prolong the duration, prolong the life of the kidney. There are other medications that have renal protective effect, like ACE inhibitor as well, diltiazem, besides the SGLT2 inhibitor as well. It's kind of renal protective effect. Okay, so now another question: what causes renal stone? Okay, and they give you a bunch of high citrate, low citrate, high calcium. So this one, high urinary oxalate and low urinary citrate. Okay, if you have high urinary oxalate, low citrate, this oxalate is going to bind calcium, causes a stone. And that's what happened with the gastric bypass. Okay, especially in gastric bypass. Okay. Now you have someone like 42 with HIV and creatine 1.7 and UA protein 3+. They tell you, okay, why? What's the diagnosis? What's the diagnosis? This one is called focal segmental glomerulonephritis. It is associated with HIV. So, if other association usually like African American obese that uses IV drug and has HIV. So IV drug, HIV, African American, and obesity. These are associated with focal segmental glomerulonephritis. How about membrana proliferative glomerulonephritis? How do you remember that? You remember that Hispanic female with rheumatoid arthritis, hepatitis C virus, and multiple myeloma. Okay? So it is common in females with rheumatoid arthritis, hepatitis C, multiple myeloma, or mixed cryoglobulinemia. How about, this is membrana proliferative. How about membranous glomerulonephritis? The way you remember it: white female with SLE, hepatitis B, taking NSAID, penicillamine, and has gold. So this causes her to have cancer. So it's associated with malignancy, NSAID, penicillamine, gold, hepatitis B virus, SLE. And there is minimal change disease associated with drugs like NSAID and lymphoma. Okay. So now you have somebody with ESRD and they tell you, okay, what's the best next step? You do IV fistula. No. Why? Because it takes time for the fistula to mature. It takes several weeks to mature. It's weeks to months. It takes 6 months. Even if, like, until they get, because when you need it, then you have it ready. Okay, just in case. Okay. Now you have 51-year-old man had renal transplant, right? So after you do renal transplant, UA shows cellular cast, and cytology shows intranuclear inclusions with atypical cells with intranuclear inclusion. And they ask you, what's the diagnosis in this case? So they add a lot of distraction, a lot of other things. This one, it's called polyoma virus induced nephropathy. Okay, this polyoma virus induced nephropathy could cause, it's called BK polyoma virus. Okay, and this is common after renal transplant and immunosuppression, and usually can cause tubular interstitial nephritis, intranuclear inclusion. Okay, so sometimes you even need biopsy to confirm the diagnosis. Alright, so now you have a patient who's 80-year-old with lethargy and constipation. You check sodium. Sodium is 158. So what's best next step for this patient? You just give isotonic fluid. This patient is dehydrated, so you just need the fluid. Okay, just as simple as that. So if you see, this is like to kind of give you an idea of hypernatremia. If somebody who has high sodium, you assess the volume status. If they're euvolemic, just give them free water supplement. If they are hypovolemic, like they require volume, if they're symptomatic, you give them 0.9 saline until euvolemic, then dextrose. If they're not symptomatic, you just give them 5% dextrose and that will fix their issue. Okay, this is for hypernatremia. And sodium should be corrected at a rate of 0.5 milligram per hour and not exceed 12 MEQ in a 24-hour, because too rapid correction can cause cerebral edema and we don't want that. So just like slow correction. Okay. Alright, now you have a patient with recurrent flash pulmonary edema, like 61-year-old recurrent flash pulmonary edema, crackles, creatine 2.8. What's best next step? They can also add reticular nodular fibrosis, crackles, and respiratory crackles, heartburn. This is scleroderma renal crisis or renal disease, so you need captopril. This is for scleroderma or renal crisis. Causes usually kidney injury in the absence of previous kidney disease. It causes marked to moderate hypertension, like 85% of the time, blood pressure more than 178, and normal urine sediment, sometimes with mild proteinuria, and cause microangiopathic hemolytic anemia as well. Okay, so this one you need treatment. You start ACE inhibitor. Even in patients with advanced renal dysfunction, you need that. Okay. Now, you see this patient's 82, have sudden back pain. You do regular lab, you check the potassium level, you see it's 8.2, so it's high potassium level. There's compression fracture. So what's best next step? In this case, you wanna, anytime they ask you to repeat test, you just like give it some thought. So this one you just basically repeat the test, may not be accurate. So you do analyze whole blood potassium by using arterial blood draw. So you do arterial blood draw, check potassium, make sure it's accurate because of, you know, treating that, because you don't want to cause issue that it's not there. So there are causes for hyperkalemia. It could be K release from the cell, like there's pseudohyperkalemia, could be metabolic acidosis, insulin deficiency, increased tissue catabolism, beta blockers, exercise, hyperkalemic periodic paralysis as well. This is increased potassium release from the cell. What the other issues like decreased potassium excretion, like for example aldosterone deficiency, renal failure, hyperkalemia, distal RTA, drugs like ACE inhibitor can cause hyperkalemia by decreasing excretion. Okay, and usually what they bring you, like they give you potassium 8.2, no EKG changes. That's what give it away, because usually potassium more than 8 causes some EKG changes. If there's no EKG changes, potassium more than 8, that's makes you suspicious. This is pseudohypokalemia. So this is what I want. It's actually common. You can see that in the pseudohypokalemia, especially like this point of care. One of our attending used to call it like piece of crap or something, because not very accurate. Okay. Now this case is kind of interesting. You see, 18-year-old man came in with weakness and confusion. Okay. So you do examination. You do flaccid paralysis, flaccid weakness on extremities. Okay. You check the labs. You see potassium is 2.4, phosphorus pure is like 2. This is very low. So hypokalemia, hypophosphatemia. So what's going on in here? So check the anion gap. Anion gap is normal. Okay. The anion gap is normal. So what is going on in here? Okay. You check. You do ABG. pH is like 7.3. There's acidosis. So there is normal anion gap, metabolic acidosis, hypokalemia, hypophosphatemia. This is weakness. What is going on in here? Why? This one, what we call solvent inhalation. Okay. And that brings us what causes normal anion gap metabolic acidosis. Sometimes diarrhea, fistula like pancreatic or ileocutaneous fistula, carbonic anhydrase inhibitor, renal tubular acidosis, urethral diversion like ileal loop, or iatrogenic. All of these things can cause normal anion gap metabolic acidosis. Okay, and toluene containing solvents can cause renal tubular acidosis with marked hypokalemia, hypophosphatemia, and these electrolytes can cause life-threatening weakness. Okay, so now let's review what we discussed. We talked about solvent inhalation cause life-threatening weakness due to hypokalemia. We talked about pseudohypokalemia. There's no EKG changes. We talked about captopril and renal crisis, azotonic fluid, polyomavirus. Talked about AV fistula now. Focal segmental glomerulonephritis. We talked about diploglyphosine. High oxalate in the urine is not a good idea, especially in gastric bypass. You want to increase dietary calcium. Well, when there's a skin rash and glomerulonephritis, this is henoscholem purpura, IgA deposition on the skin. Behavior modification first, always first, with BPH. Polyethylene glycol for urine incontinence, constipation. Thromboembolic disease if there is like a skin rash and some glomerulonephritis. ACE inhibitor if the protein above 1000. Renal biopsy was very helpful if you don't know what's causing this nephrotic syndrome. Hemoglobin electrophoresis of just hematuria. Spot urine protein if the urine protein is elevated and healthy patient doesn't have symptoms. Primary polydipsia when the urine increases osmolality after deprivation. And you want to remove the stone if there's irregular stone, 2 centimeter. Alright, that concludes the summary of the nephrology section. Thank you for listening.